Welcome to ATCM, the Emergency Medicine Channel. Presenting the case of 48-year-old male who presented to ER with complaints of pain along the throat and the chest since last 8 days, and which occasionally radiated to back, and also he presented with complaints of severe epigastric pain since the last 3 days, and along with breathing difficulty since yesterday. And he had come to ER with these following complaints following swallowing of a chicken bone while having food almost 8 days back. So on initial 10-second assessment, the patient was conscious, oriented, he was obeying commands, and he was talking in full sentences. And on primary survey, the airway was patent. There was no stridor or pooling of secretions, the gurgling of sounds or hoarseness of voice. But in breathing, the respiratory rate was 28 per minute. The saturation was 95 in room air. And on auscultation, there was presence of diffuse bronchi. And also there was a central crunching sound present on auscultation in the central chest. And the air entry was bilaterally equal. And there was a presence of a grunting sound during expiration. And on circulation, the BP was 142 by 90 millimeters of mercury, and the heart rate was 115 per minute, and the peripheral pulses were palpable and equal. And disability, the GCS was E4, V5, M6, and the exposure, the patient was febrile, and GRBS was 110 milligram per deciliter. The pain score was 10 out of 10. And so we initially, as pain management, we started with the injection fentanyl, 30 microgram, and then we give.
Why you opted for fentanyl?
Because patient had complaint of severe pain. So we suspected already there is a history of a chicken bone intake, swallowing. It was actually he had a meal after a fasting for 1 day. So he had, after the intake of the swallowing of the chicken bone, it was a forceful swallowing. So we suspected a esophageal injury or suspecting a mediastinitis or any chest injury we suspected. So due to which he is having a severe chest pain.
Okay, so why you preferred fentanyl? So what will you give if the patient is having pain? Because if you are suspecting an esophageal perforation, patients can have hypertension. Patient might go into sepsis because of the mediastinal infection.
Yes.
And also there are chances, if at all a patient is having peritonitis, there is chance of hypotension also because of hypovolemia. So if you are giving fentanyl, what are the side effects of fentanyl?
Fentanyl can, there's a possibility of causing respiratory depression also.
Respiratory depression,
then there's another possibility of causing hypotension.
Then
and
chest wall rigidity also can happen. So these are the three. Hypotension can be there, chest wall rigidity can come, and also it can induce sedation. It can induce sedation, and it is also an induction agent. Patient might go into that respiratory depression. That thing can come. So whenever you are starting analgesic, you can start off with the paracetamol, then you can gradually step up. Okay.
So as a
so what were the DDs right now?
So we had
the clinical history you suspected
esophageal injury was what I suspected initially, because due to a swallowing of the chicken bone intake.
Other DDs,
there could be the possibility of an underlying myocardial infarction is also a possibility, which gradually had progressed, because patient had complaint of a central chest pain, which radiated to back, and also had an epigastric pain along with breathing difficulty. So we can also
other possibilities.
The possibilities patient can have the possibility of a pericardial or any effusion also with pericarditis.
Effusion might not cause much pain, pericarditis might. So what is a typical pain of a pericarditis? How will the patient present? So we discussed about an esophageal perforation, that type of pain. Then we have discussed about myocardial infarctions. How will you differentiate this pain from a myocardial infarction?
Myocardial infarction, it will be like a kind of a crunching pain is what
central chest pain, like a heaviness. So
along with it could be radiation to the shoulder, radiation to the back, or radiation to the abdomen. And along with that, patient can have palpitations or associated sweating.
Sweating can be there. That is in case of an MI. Whereas in case of a pericarditis, what will happen?
And pericarditis patient could have an associated fever associated with it.
Fever can be there.
There's
Then
a possibility.
what is the type of pain in pericarditis?
It's a
Pricking type of pain. So if it is an MI, the pain usually subsides on rest. But in case of pericarditis, the pain will worsen on what position? Supine position, the pain will worsen.
Yes.
Okay. Then what are the other DDs which we'll consider? So we discuss MI, pericarditis, esophageal perforation. Then
patient could be having a GERD, reflux disease.
and such patients will have abdominal blotting, this gastritis, like burping sensations will be there. Then
you can suspect an aortic dissection also in this patient. Patient having an arch of aorta.
So what will be the pain in case of aortic dissection?
It will be kind of stabbing type of
stabbing by tearing pain in the interscapular regions. And also there will be difference in pulses also. Okay, and so we'll have to compare the all four limbs pulses also. Any other DDs?
If he's having a breathing difficulty, it could be due to a pleuritis, pleuritic pain. Then also
how will it be a pleuritic pain?
Pleuritic pain will increase on taking in
deep
breaths.
Okay.
And it's also position dependent on changing position. Moving sideways, the pain can increase depending on the side where the pleuritis is.
Then
and there is also
pleuritic chest pain secondary to a underlying pleuritis or a pneumonia.
Yes. Or previous any blunt trauma to the chest. We must ask for a previous history of a trauma. Blunt trauma to chest can also cause similar symptoms.
Or any trauma was there, there can be fracture itself can cause pain. Any abdominal causes?
Abdominal causes, hiatus hernia, like herniations through the diaphragm.
And they might not have pain as such, they will be having gastritic symptoms. Pain in the epigastrium.
Pancreatitis features. Pancreatitis is a possibility, but then
how will the patient present if it is a pancreatitis?
Pancreatitis patient will present with severe epigastric pain, which will have a radiating to back, and also that patient will be complaining of severe dehydration and
pain relieves
bending forwards.
Okay.
Yes.
Or if it is a female, 40 years.
Yeah, the presence of cholecystitis.
Cholecystitis also.
Yes.
Okay, so when a patient presents like this, if it is a not typical case, then we will have to either we will have to think organ wise from the neck, chest and abdomen, or we will have to skin inside. Okay.
Yes. So as adjuvants to primary survey, we had taken a ECG. ECG was showing a normal sinus rhythm, and on the ABG, it was showing a lactic acidosis with a lactate of about 3 and bicarb of about 19, and all other creatinine of about 2.6. He had a baseline of.
So when will you tell patient is having lactic acidosis in an ABG?
This presence of lactate more than 2.5.
So presence of lactate doesn't always cause lactic acidosis.
Yes.
So if the lactate goes more than 4 only, the patient will have acidosis secondary to the high lactate.
Yes.
Okay, so we can tell that there is hyperlactemia, but the acidosis might be contributed by something else also. Anything else? What?
Yeah, he had a creatinine worsening. He had a baseline creatinine of 1. Now it has rose to 2.6.
Okay, so maybe the renal failure has contributed to the acidosis.
Yes,
okay.
And we had also taken a point of care CBC counts to look for the total counts in CRP. The total counts was 13,200 along with a CRP of 169.5. And so we came to we understood that there was an infective pathology involved, which is causing a sepsis is a possibility because patient already has a creat worsening.
Okay.
So involving
Acute
multi
kidney
symptoms,
injuries
acute
also there.
kidney injuries there. We have the sample history. The 48-year-old male, known case of type 2 diabetes mellitus since last 10 years. Presented to ER with complaints of severe throat pain since 8 days, also along with chest pain, central chest pain since 8 days, radiating to back, and also had a severe epigastric pain since last 3 days, and also with severe breathing difficulty yesterday, and following the swallowing of chicken bone 8 days back.
Okay.
And the patient had no history of any hoarseness of voice or dysphonia or any there was a history of one episode of vomiting. So there was one episode of vomiting and multiple episodes of retching was also present.
Okay.
And there is no history of any hematemesis or melena, no history of any dysuria or decreased urine output. And then moving on to allergic history.
Okay, so how did you suspect esophageal perforation? Did he go to some other hospital?
Yeah, he went to other hospital. So initially, from there, in other hospital, they had taken an X-ray. X-ray, it was 4 to 5 days back, which showed an air in the mediastinum. And for that, and also patient.
How will we see air in the mediastinum?
Mediastinum. There's like presence of a radiolucent lesion is in presence on the central.
So, if the patient is having subcutaneous emphysema and all, what we will see? We will be seeing the soft tissues of the skin, the muscles will be seen, and in between that, we will be able to see air pockets. That, if the patient is also having subcutaneous emphysema, that might not be present in case of a lower esophageal perforation. So, in a pneumomediastinum, how will the mediastinum look?
There will be widening of mediastinum. Widening of the mediastinal contents. Along with that, there will be associated lung decrease in lung volume.
Thing is, we won't be able to see the X-ray will not be looking much clean because there is because there is pneumomediastinum air content. We will be seeing a dirty lung picture will be seen. Along with that, we will be seeing the heart shadow very prominent. Heart might be, if at all mediastinum is there, that heart will be having an outline with a black color outline. That is because of the air. Okay.
So then the allergic history, there is no history of any allergy to any medications or food. Medication history, patient is on glimepiride 1 mg and also on metformin 500 mg. Past history, patient is a known case of type 2 diabetes mellitus since last 10 years and is also having a history of alcohol intake since the last 15 years, and this last alcohol intake was 8 days back during the intake of food, and there was no history of any smoking. The last meal was taken 6 days back, so he was kept NPR from the outside hospital, and then following that we came to a differential diagnosis that it could be a possibility of an esophageal perforation leading to a mediastinitis.
So what all contributes to, with the history, what all things contribute to esophageal perforation in this patient?
The patient already has a prior trauma due to the swallowing of the bone. And then next he's having
so foreign body impaction causing a trauma to esophagus. Okay,
then he initially presented as a throat pain 8 days back, which then gradually progressed into a chest pain. Throat pain with chest pain was in his initial presentation, which gradually progressed to an epigastric pain. So this showed a gradual progression. So that could be due to an underlying mediastinal inflammation, because also the patient has a raised CRP. So could lead to a possibility of an inflammation in the mediastinum.
No, from the history wise, from the sample history, why did
the patient also has a history of alcohol intake along with multiple episodes of retching.
Alcohol can contribute to a there is a chance of esophageal perforation secondary to an alcohol ingestion and retching. And you are telling that patient had vomiting and retching. So what else can contribute?
Yeah, that can lead to an esophageal tear. That is called as the Borhave syndrome. So the Borrelli syndrome, it contains, it usually involves the chest pain, which is usually occurs after multiple episodes of retching,
Okay.
and which is usually precipitated by an alcohol intake.
Okay.
Then there is also presence of the macular triad. Macular triad is mainly presence of chest pain along with vomiting and also presence of subcutaneous emphysema. But in this patient on examination we couldn't find any
Okay.
subcutaneous.
So you were talking about Borhaus syndrome. Borhaus syndrome is the perforation of the lower esophagus. So if it is a perforation of lower esophagus, mostly which side will it get perforated? Left or right? Mostly left lower esophageal perforation. Okay.
So that's one of the possibility, because patient already had a binge alcohol intake also, like patient alcohol intake.
Okay. Did the patient, so some of the etiologies for esophageal perforation is one, Borhaus syndrome, retching, binge alcohol intake, any foreign body impaction, then anything that can increase the esophageal pressure, like a seizure, a violent cough. This also can contribute to an esophageal perforation. Then any other conditions?
Usually almost more than 50% of the cases of esophageal perforation is due to an endoscopy, like iatrogenic. So iatrogenic is one of the most common causes of esophageal perforation. Usually the esophageal perforation, it is occurring, there is a possibility of esophageal perforation in the cervical esophagus, because mainly in the region of the Killian's dehiscence.
Okay.
There is an anatomical region called Killian's dehiscence in the posterior pharyngeal wall, which is between the inferior constrictor muscle and also between the cricopharyngeus muscle. So that layer is, which is deficient. So there is a initial, there is a high chance of getting an injury to that area and causing further perforation injury. And then also the constrictions of the esophagus. We have three main constrictions in the region of the esophagus. First one in the region of the cricopharyngeus muscle, second in the bronchoaortic constriction, and also in the esophagogastric junction. So three constriction sites, there is a increased risk of foreign body impaction causing perforation in the esophagus. So that's also a possibility.
Any known conditions that can cause perforations? Like if the patient is having a history of achalasia cardia, that can increase the esophageal pressure and cause perforation. Or any history of Barrett's esophagitis because of the reflux, that will be causing the narrowing of the esophagus. Or this patient, we have told patient is an alcoholic patient. So alcohol, if at all there is varices, that also can cause thinning of the esophagus. So clinically, so this is based on the history. Clinically, how did you find out this is esophageal perforation?
Clinically, the patient, like on vitals wise, patient had an associated tachycardia and tachypnea, possibly due to the pain. And this patient also had on examination, on auscultation, mainly on just auscultation. There was presence of a crunching sound on auscultation, which we mainly found out when patient was on a left lateral position, which is called as a hum and sign. So that crunching sound was present on auscultation. Along with that, patient had a bilateral wheeze, sound also, and patient had a grunting sound also. So that's a possibility.
What all are the other clinical things which we'll have to look? This patient had Hamann sign and all. What all other things we should look from the neck?
So usually in the cases of esophageal injuries, it is mainly depending on the site. So mainly if patient is having cervical esophageal injury, patient usually presents with complaints of throat pain. So patient initially with throat pain, and patient will also have complaints of hoarseness of voice and dysphonia. So dysphonia is also would be another complaint, along with patient will have a crepitus. So crepitus, neck multiple subcutaneous emphysemas will be present. So that will be the presentation in the case
because of the air leak to the neck.
So that will be the presentation in the case of cervical esophageal perforation. In the case of if patient is having a thoracic esophageal perforation, there is the possibility is mainly patient having a central chest pain, which will be radiating to back or can radiate to the left shoulder also. Along with that, patient will be having this Hammond's sign is usually a character of thoracic esophageal perforations.
And tachypnea and tachycardia can
is also
be
present.
there.
Yes.
So, if it is in the thorax, patient can have mediastinitis and pleuritis also can be there. And pleural effusion might be there. Either because of the perforation as such, because of the inflammation, or because of a ongoing infection. Okay.
So if it is in the intra-abdominal, so in the lower esophagus, in the intra-abdominal part, the patient will be presenting with severe epigastric pain, and also with that patient will present with a rigid abdomen. So the abdomen could be peritonitis, signs of peritonitis. Along with that, patient can present also with hematemesis or melena, because there could be underlying bleed also underlying with it.
Okay.
So these are usually the presentations with which patients with esophageal perforation.
Okay, so what all investigations do we need to do?
So there are actually the ideal investigation which we can do if patient is stable is we can do a CCT of chest with the abdomen. That is the investigation of choice.
From the beginning from basic investigations.
We can do a ultrasound.
Okay. So in the ER we'll have to do basic test. We'll have to, here we are suspecting infection, so we can do ABG, CBCRP can be done. A chest X-ray need to be done to look for any dirty lung picture. That should be any pneumomediastinum, along with pleural effusions should be checked, and abdomen X-ray to look for any air under the diaphragm. That should be done, and the chest X-ray we need to look for the subcutaneous emphysema. That should be checked X-ray. Then
we can do a USG lung to look for USG chest to look for collections in if there is any underlying pericardial effusion or underlying pleural effusion associated. Collections in the mediastinum can also be assessed by ultrasound. Then we can do a CCT.
So CCT is so these investigation which we told initially are the initial investigation. Investigation of choice might be a CCT. So when we are asking about investigation, you need to first tell about the initial investigation, then the definitive investigation. Okay. So what was done for this patient?
This patient initially the CCT was done, and for that CCT chest was showing there was no presence of the radiodense bone was not noted, and there was
foreign body was not
noted. The foreign body was not noted, and there was presence of an ill-defined collections with air lucency in the paraesophageal region, mainly in the thoracic esophagus.
Okay.
So the thoracic and there was suspicion of an acute mediastinitis.
Okay.
And a thoracic esophageal perforation. They immediately had shifted the patient to OT, and they had done an intra-op.
That is definitive. When you are telling about management, we'll have to tell about the initial management and management of the definitive management.
Yes,
so what was done in the ER?
Initially the first thing is we kept the patient NPO because already patient is NPO, but we further continued it off, and then patient he's having severe pain. So initially we did his pain management. Following which that also patient will already has severe signs of exhaustion, and patient had dehydration associated. We give IV fluids. Along with that, patient has a associated mediastinitis infection is already present. So we must provide an antibiotic cover. Since this patient already has a presentation of more than 48 hours following the incident, in such esophageal perforation conditions, we must suspect a sepsis even without blood reports. So we must start on broad spectrum antibiotics, which involves the piperacillin tazobactam we can use, or we can use ampicillin sulbactam we can use as an antibiotic, or carbapenem we can use. As an adjunct, we can use clindamycin also. We can use anaerobic cover. And then for long-standing, since it's already 8 days, we must also add an antifungal cover for this patient. We added a fluconazole also 400.
Okay.
So that was what
that is the ER management, and we'll have to give a surgical
consult.
Okay. Then what was the definitive management done?
For this patient, the patient upon doing the before mentioned definite the investigations. The patient was taken for an emergency OT procedure, following which they had done an OGD-scopy. OGD-scopy, it was showing a mucosal rent in the thoracic esophagus, and so they immediately done a transhiatal esophagogastrectomy was done for this patient, and following which now he is able to. Currently, his status is able to take oral feeds at present. He's on swallow therapy at present.
Okay. Anything else?
The management of the perforation. There is actually a non-operative management for the esophageal perforation. If not all esophageal perforation need not be operated immediately. In cases of patient if presents within 24 hours, there is no need of a definitive surgical management for such patients. Or if patient is having a stable hemodynamics, we don't need to intervene quickly. Or patient has even if patient has a cervical perforations, usually some cervical perforations can heal by itself. So there's actually we can wait and watch. And also perforation, if it is actually contained perforation, with no features of any mediastinitis, this contained perforation can go back into the esophagus. So in such conditions also operative management is not required, and if the patient does not have an underlying esophageal disease also, that's also one of the reasons.
Okay. Anything else?
Yes,
Okay, thank you.
thank you.